So good morning, good afternoon, and good evening to all our listeners who've joined us today. Dear friends, dear colleagues, welcome to the session on what you have missed at Ifso 2022. The 25th World Congress of Ifso was held in Miami in August. This meeting, initially scheduled for 2020, was postponed for the first time and then again in 2021 due to the COVID pandemic and also the travel restrictions. We finally had a meeting this August at the Hotel Fontainebleau in Miami. Now, this meeting was unique in that we also had the two biggest chapters of Ifso participating in the Congress. The ASMBS, the American Society for Metabolic and Bariatric Surgery, and the Latin American chapter. Now, those of us who went will say that the meeting was a resounding success from so many points of view. Miami put out their best warm weather. The venue at the Hotel Fontainebleau was first class. There was great presentations from all over the world. The scientific sessions were well attended, and the interaction, camaraderie, and discussions were fantastic. So today's session is for those of you who attended but did not get to all the sessions, and more so for those who did not attend, to tell you what you missed out and to make sure that you attend our next World Congress in Naples starting on August 30th, 2023. I'd like to thank Ahmed Bashir, who is our chair of a communication committee of Ifso, for taking the lead in the panelist presentations today. Now, this session is recorded and will be available at the Ifso website probably later on today. So I'm going to invite Ahmed Bashir to say a few words and to introduce the panelists and start the discussion. Over to you, Ahmed.
Thank you very much, Lillian. I'm one of the guys who missed actually Ifso Miami, so it was a great opportunity to actually review the abstract book, and the entire communication committee reviewed 450 oral abstracts between us all, and we chose the best 3 to 4 per reviewed session. So without further ado, maybe we can start the presentation to save some time, and we'll start with my friend and colleague from United States and New Jersey, Dr. Alan Sauber. He's a clinical professor of surgery at Rutgers Medical School, and he's also the surgeon champion for MBSA QIP program at Beth Israel Medical Center and the program director for bariatric surgery there. So maybe Manuela, can we share the slides?
Thank you, Ahmed. The meeting was a great meeting. We enjoyed a lot of presentation and from all over the world. Great job, Lillian and Nathan and Raoul. All right, so the first abstract I chose about cloud-based artificial intelligence driven video analytics for bariatric surgery to enhance surgical training and mentoring. As we know, there is more and more interest in recording videos, whether selective or routine. And over the years, we're seeing evolution of the way of saving videos and the interacting with videos, from having saving video on hard drive to now automated cloud platform. So this article coming from UK, basically overview of 3 common platform: the theater in, touch surgery, and CSAT in bariatric surgery. And what they illustrate that how this 3 platform important for storage. Storage is automated. Storage is endless, you have big capacity and also secured, and also how they can utilized in surgical education, analyzing the video into segment and sharing this segment between us. So it's a good communication tool. So they conclude that artificial intelligence component of cloud storage is very important for training, performance, and standardization of surgical procedure. And we're seeing more and more adaptation to this technology. Ahmed,
So,
any?
Alan, as a program director, do you utilize any of those platforms?
Actually, we're in the process of having one of cloud storage from one of the companies coming soon. But I can tell you, just storing the video on hard drives can be a potential issue. So this facilitates a lot of storage, peace of mind, so you don't worry about if you forgot to record or not. It's automated. The size, you can upload as much as you can, and also for training you can segment, divide the procedure into segments, and having the fellow or the resident just reviewing a segment of or a step of the procedure across the board. So you're seeing any issue happen in the OR, how is what the routine, what the pattern. So it's very good for surgical education.
Sounds great.
Let's move to the next abstract. Great, thank you, Minawalla. So the next abstract, changing the quality of life in adolescent bariatric surgery. It's a paper coming from Israel, prospective study. As you look at 97 adolescents who underwent bariatric surgery, and the evaluation of quality of life was done through questionnaire that was sent before and after 9 months after surgery. What they found, in addition to how is adolescent bariatric surgery can significantly improve BMI, also they found a very good impact on quality of life, increasing the energy level, mood level, mental health, as well as social parameter improve. So it's a bariatric surgery in adolescents. They give me a meaningful decrease in the BMI, as well as improving quality of life. Interesting, the amount of weight loss is not correlated with the amount of improving quality of life. Ahmed, any question?
So it's interesting that you brought up this. Hopefully, with the new guidelines, we have encompass adolescents and children surgery more and more within our practice. It would be interesting to see the long-term quality of life stressed, because this is one of the few quality of life papers that I see that's stressing all these points. What do you think, Alan?
Yeah, I agree with you. I think the whole field of adolescent bariatric surgery is still early on. We're seeing more and more program interested in doing adolescent bariatric surgery, and the quality of life will be a key component in how is bariatric surgery affect adolescents. Great. Let's move to the next slide. Great, thank you, Manuela. So the third one about cost effectiveness for sleeve gastrectomy. Should we do the sleeve and keep the patient in a short stay unit, or we admit the patient as inpatient? So this study coming from Singapore General Hospital, a prospective non-randomized study. They compare two things. They compare sleeve gastrectomy that's done and the patient kept on at the short stay unit versus admitted to the hospital. And one of the difference also, they add the component of hydration clinic. As we know, one of the most common ED visit or readmission is dehydration. So can the combination of short stay sleeve gastrectomy in addition to a hydration clinic, save cost saving as comparing to inpatient. So what they found, clinically equivalent. So whether you send the patient home after short stay or you keep the patient in the hospital, however, this significant cost saving we're seeing more and more in the United States, and I'm sure all over the world, about ambulatory bariatric surgery. The key here also the hydration clinic. Hydration clinic decrease readmission. So instead of the patient called the emergency department, as we all know, our emergency department very busy. Sometimes the patient stay for a long time. Now this is a clinic that the patient can call and come directly, getting some fluid resuscitation, get assisted, and go home. And they found this significant cost saving when you have this hydration clinic. Back to you, Ahmed.
It would be interesting to note, did they account for founding those hydration clinics as a cost? Because we don't have those in general worldwide, but the idea is very interesting and appealing for patient care. But the cost of building the hydration clinic, not sure if feasible all over the world.
Yeah, you see, Ahmed, very interesting comment, but a hydration clinic doesn't have to be a brand new hydration clinic. All our hospitals, they have like infusion center for people has hematological disease. They come, they get some, they get some transfusion, or maybe a dialysis unit. So basically, any unit in the hospital that has nurses, that patient will come in, they will call, come in, and they get evaluated quickly by certified nurse, and the physician can see the patient, and they give them like a liter or two of banana bag thing, then they will go home immediately after. Much better and much convenient to the patient than staying in the emergency department. Thank you.
Sounds great. Thank you very much, Alan. Let's move to our next speaker, my dear friend Zahir Toomey, consultant bariatric surgeon from University Hospital of North Durham in UK. Please, Zahir.
Thank you very much, Ahmed. And I was among those who were very fortunate to go to Miami, and we definitely had very good time. So don't miss Ifso next year, friends, especially you, Ahmed. It was really difficult to select a few abstracts out of the number of abstracts which I was asked to look at, because there were a lot of abstracts with very good quality. Anyway, I selected 3. The others are also very good. So this is first study. It comes from France, and it looked at patients who underwent conversion from sleeve gastrectomy to gastric bypass. Out of 133 patients who had conversion from sleeve to bypass, 51 had the conversion for gastroesophageal reflux disease. 37 of them had it for reflux disease exclusively, and 14 had it for both reflux disease and weight regain. Among these patients, there was esophagitis in a proportion of them, and only 5 patients had a grade C or more esophagitis. It's interesting that there was resolution of reflux symptoms in 78% of patients at 6 and 12 months. But if you look at the data, when the patient was last followed up in the clinic, only 55% of the patients had resolution or had remission of their reflux. It's interesting because frequently gastric bypass is presented as a solution for reflux disease in patients who have a sleeve, but in a follow-up with a median of 23 months, only 50% of the patients had resolution. And I think this really needs to be taken into account when we consult our patients who suffer from reflux after having sleeve gastrectomy. Thank you.
So I wonder what their definition of remission was, because we know if you rely on symptoms, that definition is really vague, and the use of PPI as well, because use of PPI is actually high after gastric bypass, especially when you consider smoking, use of NSAIDs, and marginal ulcer chances. So what do you think there?
I think, you know, the study, it's clear in terms of its objective. It looked at patients who are symptomatic rather than patients who have endoscopic changes. And the aim was to look at symptomatic control rather than at resolution of endoscopic findings. And clearly within the abstracts, you can't see all the details of the study, but this is how it seemed to me. But, you know, the indication was symptoms, but the treatment didn't seem to resolve the symptoms. And this is where I think the importance of this paper is that we need to think about this when we give patients an advice, because, you know, possibly there is potentially a dogma that Roux-en-Y gastric bypass is going to get rid of your reflux symptoms if you had a sleeve. That might not be the case.
Great.
Thank you. Next slide, please. This is a very interesting study from Israel. Very large series, 6,700 patients who had one anastomosis gastric bypass. About a quarter of them had revisional surgery, so previously had a bariatric procedure, and a third of them had additional procedures at the same time, whether it is repair of hiatus hernia or cholecystectomy. But the outcomes were excellent, and very low level of early adverse events, so 3.8%, less than 1% of the patients required reoperation, 1.9% required readmission, and mortality was 0.03%. So essentially, excellent short-term safety post one anastomosis gastric bypass.
Yeah, seemed like excellent results, and a good operation nowadays that is being endorsed by all societies.
Thank you. In this study, I think possibly it combines the previous two, and this is looking at one anastomosis gastric bypass as a revisional bariatric procedure. It comes from Dubai. It looked at 65 patients. Average follow-up was 41 months. Excess weight loss was good, 74% compared to the weight before the procedure. Diabetes remission was 62%, but all comorbidities except gastroesophageal reflux disease improved or resolved, while gastroesophageal reflux disease worsened. They also mentioned anemia worsened. But in my view, this again, it should alert us to utilization of one anastomosis gastric bypass post-sleeve gastrectomy, especially in patients who suffer from gastroesophageal reflux disease. And in this series, those who suffer from gastroesophageal reflux disease, the reflux worsened after the procedure. And so beware when utilizing one anastomosis gastric bypass after sleeve gastrectomy in patients who are affected by reflux disease.
So this again stresses another paper which talks about convergence to one anastomosis gastric bypass from various procedures, and they mentioned the same thing, the trend of worsening reflux when you convert other procedures to one anosmosis gastric bypass. So a very interesting finding indeed.
Thank you.
So let's move on to the next speaker.
All right, the next speaker, my friend, is Dr. Abdurrahman Numairi. Abdurrahman is the Chief of Bariatric and Metabolic Surgery, Director of Atrium Health Weight Management, Director of Bariatric Fellowship Program at Atrium Health Carolina Medical Center in North Carolina, United States.
Thank you, Alan. So I had the privilege of being at the meeting in Miami. I chose 4 papers for you. The first one is a paper that looked at a systematic review and meta-analysis of patients who had bariatric surgery. So they looked at 1,428 articles and picked 16 match studies from them. And they were trying to look at the mortality after bariatric surgery. So they had 174,000 patients, and they found that bariatric surgery had a risk reduction of mortality with a hazard ratio of about 49% and the confidence interval 46 to 51. And this was statistically significant. What was important is that they found that the median life expectancy was 6 years longer for patients who had bariatric surgery. And in diabetic patients, the effect was more pronounced compared to non-diabetics. And obese patients who had bariatric surgery had lower all-cause mortality as well. So the study highlights that in patients who have severe obesity or have diabetes, if they had surgery compared to a control group, there is a mortality benefit.
Great, thank you, Abdurrahman. How we explain this? Life expectancy is longer in after bariatric surgery in diabetic versus non-diabetic. I expect the opposite. So I don't know if just this is a finding or this has scientific basis in this article.
In general, diabetic patient, I mean, the 2 main ways by which mortality is increased in patients with obesity, as you know, is heart attacks in men and women, and cancer in women specifically. And diabetics, by default, have more likelihood to have more cardiovascular events, especially if you look at major adverse cardiovascular events. And one of the 4 papers I'll present will also show similar things from a Canadian study.
Thank you. Thank you.
Next. So the next paper is from the Brigham system in Boston. And what they did is they instituted a multidisciplinary weight management team that includes surgeons, obesity medicine specialists, and gastroenterologists. And they wanted to look at the effect of that on care. So they found once they instituted that, the total clinic volume of all the specialties increased by 109% at 2 years compared to before they instituted the model. And this was statistically significant. The new patient volume increased, and the number of patients who are seen by more than one division increased. The growth in obesity medicine was the highest, about 233%, followed by the growth in GI, meaning endoscopic therapies, and the least amount of growth was seen in surgery, 7%. But if they look at the procedural growth, the highest procedural growth happened in the surgical bariatric surgery, and it was 42%. So this study highlights that once you institute an MDT team, you end up not only increasing the volume, but increasing the flow of patients to the obesity medicine specialists.
Thank you, Abdurrahman. Actually, I'm in Boston now, so very interesting how we explain the total volume increase. 2 years is almost double after 2 years from starting the center. Is this attributed to attracting new patient, or this has to do with the workup before surgery? Patient go through a cardiac eval and a pulmonary eval and psych eval. What do you think?
Sure. So the GI fellow who presented this was asked a similar question, and they said that they like experienced an increase in new patients, and in their abstract they showed that their new patient volume increased as well. So it was not just that these were patients being referred across specialties. These were new patients, and obviously with the new medications, this is not surprising.
Thank you, Abdurrahman.
So the next two articles are from the same group in Ontario, and they looked at a matched analysis. So all these papers are top 10 papers. So the next two looked at matched analysis of patients who had surgery compared to patients who didn't have surgery, and looking at the incidence of major adverse cardiovascular events, mortality, MI, and having a stroke in patients who are obese but not diabetic, obese and diabetic. So in this first one, they looked at 2,600 patients, 1,300 in the surgery cohort, and 1,300 were control. They had a follow-up of about 5 years, and the rate of major adverse cardiovascular event was 11.5%. So in the surgery group versus close to 20% in the control group, and the hazard ratio was 0.58, and the confidence interval was 0.47 to 0.71. The mortality was 4% in the surgery group and double in the control group. And specifically, when you look at patients with congestive heart failure, the rate of major adverse cardiovascular events was higher. It was 17% in the surgery group and close to 36% in the control group. And there was a composite reduction of major adverse cardiovascular events of about 38% in patients who had surgery. Again, the study shows that if you follow patients who are matched, a group that had surgery, mostly for obesity, compared to a group that did not have surgery, matched for 20 variables, that the patients who had surgery have less risk of major adverse cardiovascular events.
A very interesting article, again emphasized the importance of bariatric surgery for second prevention of cardiovascular. Thanks.
The next slide, and the next one is a very similar design, and the only difference is it was done in diabetics. So they looked at 6,400 patients, 3,000 in the surgery group and 3,000 in the control group, and they found very similar results. Mortality, 2% in the surgery group versus 7% in the control group. And across all durations of diabetes, the surgery had a consistent reduction in mortality of a hazard ratio of about 0.26. And males and females were both benefiting. And the numbers needed to treat was about 11 patients and 14 patients. And if the patient was older than 55, the numbers needed to treat was 13 patients. And the risk of cardiovascular mortality decreased by 75%, and a composite major adverse cardiovascular event score that they described showed a 34% reduction. So again, patients who had surgery or diabetic were less likely to have major adverse cardiovascular events.
That's great. Just emphasize your conclusion of the first paper. So that's why we changed the name of bariatric surgery into metabolic surgery. Thank you, Abdurrahman.
That's correct. So I think next, it's my pleasure and privilege to introduce Dr. Marina Kurian, and she's a clinical professor in the Department of Surgery at NYU in New York, and she's the president-elect of ASMBS. Marina.
Thank you so much. This has been so informative so far, and I hope everyone who's watching is really enjoying it. Great Great abstracts that you guys all picked. So our process was to look through about 50, 60, and each one of us picked our top 3. I unfortunately picked 4 because I came across an extra special one. So, so we had, the first one is on duodenal ileal diversion with self-assembling magnets. I know of 2 companies so far that have magnets that are going to connect the bowel without surgery, which, you know, ultimately will decrease our leak rates and, you know, will improve patient throughput through our system. So it's going to be very interesting. And in this, they did 18 patients and they deployed self-assembling magnets in the ileum, which was placed laparoscopically. And in both the companies, this is how they're doing it, as a laparoscopic assisted magnet placement. In one company, there is no incision into the ileum, and in the other there is. But so these magnets are deployed, and then the second magnet is placed in the duodenum, and then they follow these patients, and it's a very short-term study, but there's no leak, there's no device-related adverse events, and then the total average total body weight loss, which is what we're looking at, which is very important, at 1 month was 7.3%, and at 3 months was 15.5% total body weight loss. So this is actually what we get now with semaglutide, and I'm thinking that if we follow this out to 6 months, you'll see more than you get with the newest drug that's out there, which is a GLP-1 and a GIP, which in the US is called Mounjaro, but I don't know, it's tirzepatide is the other name for it. So very interesting things, and this is by transit. So it's a very interesting method and physiologic process.
So Marina, do you think this could lend itself to doing low risk SADI in the future?
Absolutely, and I think that there's something about by transit that really enhances weight loss more than doing a diversion. So I think it's very intriguing, and definitely, especially if people are concerned about sleeve revisions and what are we going to do. I mean, if you're worried about dissecting the duodenum, which by the way, I love the duodenum, so I'm always there. If I can be there, I love it. But it's, you know, this will be an option for a lot of surgeons and patients, I think. Next slide. So this, I've been intrigued by this. This is something that I do in my practice. I look at my patient's trajectory. I've spoken about this many times, mainly because I do medicate a lot of my patients if they're off track. And this is over 1,100 patients who went bypass between 2013 and 2016. And they looked and saw that 48% of the patients, if they achieved less than 5% total body weight loss at the first postoperative month, then that predicted that they would be around 20% total body weight loss at 1 year, which for a bypass is unheard of, right? Like we expect it to be, you know, my rough translation for total body weight loss to excess weight loss is just about twice. So if you look at total body weight loss of 20%, we're talking excess weight loss at 40%, right, in 1 year, which we expect 66% of excess weight loss at 1 year. Then they saw that if you're losing between 5 and 10% at 1 month, those will be predicted to have greater than 10% at 1 month, and also they would, at the 1 year mark, be losing more weight as well. So what they found were that the predictors would be that if you had less than 5% at 1 month and less than 10% at 3 months, that this would be associated with suboptimal weight loss at 1 year, which means this is your time to intervene. Now, historically, I would wait like 6 months, 9 months, see how they're doing before I added stuff. But I think this is a good way to predict who's not going to do as well, and let's give them some extra help with medication, you know, at 1 month and at 3 months.
Right, and I think this I totally agree with you, and this matches the analogies we draw between obesity and cancer. You know, when someone has a high risk colon cancer, treatment starts, you know, right away. And maybe this is another reason why, you know, we should continue to have MDTs, and maybe the surgeon, just like cancer surgeons, needs to only do the surgery, and the long-term follow-up, even from short-term, be done by the medical team.
Well, I don't know about that. I do both, but you know, I do love to operate, but I do both for the patients. But I think it's just, you know, I'm by myself in private practice, right? So I try and take care of them. And I have an NP help, but you know, that slide that you presented on the multidisciplinary team, that's also great. I will say I'm involved at 2 institutions, one that has a very strong multidisciplinary program at NYU, and it's hard to get an appointment. So when they see you, you might be able to start them on something. Anyway, let's go to the next slide. So this is coming up. It's being done in Europe. It's already got a CE mark, I think it's called, not an FDA mark. We don't have it approved in the FDA yet. This is the Ellipse intragastric balloon. You don't need any endoscopy to place it. You do need a doctor to make sure that the marker is in the stomach, so there is an x-ray involved. And then they're looking at 509 patients at 9 different centers. And what was really interesting, which is not what I found in my my balloon patients, and I used the fluid-filled and the air-filled that are FDA approved in the US, that at 4 months, their percent total body weight loss was almost 14.5 kilos, and that 1 year after the balloon passed, they were still maintaining off 14 kilos. What's not clear from the abstract is if these patients were medicated, but that's pretty impressive that the patient was able to keep off the weight at 1 year after the balloon. And there was a usual adverse events in terms of intolerance, gastric dilation, and perforation requiring laparoscopic repair, pretty low instances, and the higher rate, I think, than I've ever seen of patients passing the balloon by vomiting. Not seen that.
Right. And are these balloons that stay for the entirety of the year? I mean, I'm aware that the Allurium balloon only lasts for 4 months. Like how long do these balloons last?
Oh, I was just being told that these the balloons last 4 months, and in most people, sometimes it might be a little shorter. So it's not designed to stay. And although I believe they're working on a new balloon to last a little longer, like 6 months.
So to have this reach a year, that means you put 3 balloons in the patient. 4 months, 4 months, 4 months.
I believe there's a protocol for this where in certain countries, like I talked to one of my colleagues in UK, and you can put the balloon in, and once you establish that it passed at 4 months, 8 weeks after that, so really around 6 months, you can place a different balloon. And most people who've done balloons will wait a few weeks in between balloon placements. And I think in the US, we usually wait about 3 months, but since this is a smaller balloon than we place here, I think it might be feasible. And I think the reason for that is to allow the stomach to regain its tone. Next slide, please. So this is my 4th. I'm sorry, I went 4. I'm usually a rule follower, but I didn't follow this time. So this is, I wanted to present it because it's the MERIT trial. My dear friend, Eric Wilson, dragged this across the finish line with Barham Abudaya, also a very, very good friend. This is endoscopic sleeve gastroplasty. I know many of our colleagues around the world are doing it. I have good friends in the US who are doing it, both advanced GI and surgeons. And in this case, the MERIT study was done across multiple centers, 9 of them, 5 gastroenterology and 4 bariatric surgery, just to show you that there was collaboration between the surgeons and the GI group, both academic and community practices. 208 patients were randomized to ESG or lap sleeve, and what they found was 52% of at 52 weeks, percent exercise weight loss in the ESG group was 49%, and total body weight loss was 16% at 52 weeks. So this didn't actually meet up my doubling the total body weight loss, but I believe that's because their BMI was lower. So, you know, you can double the off topic, you can double the total body weight loss, and it'll approximate excess weight loss when your BMI is over 40. But anyway, so there's still total percent body weight loss was 16. That's pretty good. But it's equivalent. It's equivalent to semaglutide, and maybe a little less than the tirzepatide. But when you add them, I think this brings up that you can add medications to this, which they have already now started different studies to add medications to the ESG to approximate what we get in surgery.
So some surgeons are concerned that after you do an ESG, it becomes difficult if you need to do a revisional surgery like a sleeve because of the procedure itself. Any experience with that?
Yeah, I've taken these out. You have to have an endoscope in. You scope them yourself, or you have if you don't scope, you have an endoscopist in the room, and you see where the fasteners are. You don't want to come across them. Your knife won't fire and your staples won't fire. So it's you do have to be a little bit careful. But I recommend having the scope in. It's the only time I use a scope as a sizer. I always use a bougie, but when I have to do a revision, I absolutely do that. And I'm all done then. Okay, thank you so much. And it's my pleasure now to introduce Pedro Martinez Duartes, who is the head of bariatric and metabolic surgery at the Austral Hospital in Buenos Aires, in Argentina, and he is professor at the Faculty of Biomedical Sciences of the Austral University, past president of SACO. Welcome, Pedro.
Thank you, Marina. Hello, everyone. And I also choose for abstract. And the first one from UK, the end of this retrospective study was to compare the long-term outcome, 5 years of sleeve gastrectomy and Roux-en-Y gastric bypass in patients with type 2 diabetes from a prospective maintaining database. And there were 42 patients with type 2 diabetes, 18 under sleeve gastrectomy, and 24 under gastric bypass. The baseline characteristics were similar, and there were no mortality and no patients were lost to follow up. At 3 years, diabetes resolution did not differ significantly between groups. However, at 5 years, the rate of diabetes remission and resolution was higher in the bypass group. No patient in diabetes had deterioration in the, no patient in the bypass group had deterioration in their diabetes. In conclusion, Roux-en-Y result in sustaining resolution of diabetes compared with sleeve gastrectomy at 5 years. A sleeve gastrectomy can result in deterioration of diabetes from baseline and therefore cannot be recommended to treat type 2 diabetes.
Wow, I mean, it's somewhat expected that we do see better weight loss and sustained weight loss at 5 years, but I love the angle on the type 2 diabetes. And I would play devil's advocate and say you could do a sleeve and then just add a GLP-1, right? That's not what this study is looking at.
Yeah.
But
yeah,
this is one of our colleagues.
Yeah, I'm sorry.
You know, one of our colleagues, Saeed Ikramudin, who is at University of Minnesota, has done a lot of work along with some of our Indian colleagues with diabetes and assessing what the issues are. And he has currently stopped doing duodenal switch and just does a sleeve and adds a GLP-1. He does it, and so he has really impacted those patients with less surgery.
Yeah, it's what we was discussing before, is when we have to start doing this treatment like cancer, you know, we have to use both options together. It's one of the important things to know that we are treating obesity, which is a chronic disease, and we need all the tools together.
Absolutely.
Yes. Okay, let's move to the next paper, please, Manuela. It is from Australia. And the aim of this study was to evaluate the long-term outcome of sleeve gastrectomy with a follow-up up to at least 15 years in terms of weight loss, remission of comorbidity, conversion, and patient quality of life. It was multi-center cross-section study, University hospital-based, and include all patients who had sleeve gastrectomy before December 2005 at the participant bariatric centers. And the result was 53 patients met the inclusion criteria and with a minimum of 15 years of follow-up. Initial BMI was 48. 26 patients were converted to Roux-en-Y gastric bypass due to weight regain and reflux within the follow-up period. The excess weight loss after 15 years was 57% in the non-converted groups and 65% in the converted groups. Patient remission rates of comorbidities and quality of life were stable over the long-term follow-up. In conclusion, 15 years of sleeve gastrectomy, a stable post-operative weight was observed, but at the cost of a high conversion rate. Patients converted to Roux-en-Y were able to achieve further weight loss and preserve good remission rate of comorbidities. So, therefore, a careful preoperative patient selection is mandatory when performing sleeve gastrectomy in obese patients. That is the final thought of this study.
You know, we've said this for years, right? In bariatrics, like when the band was so frequent, they're like, who would be a good band patient? This is who's, you know, who. Then everybody else only had the other option of doing a bypass or doing it on switch. So it's hard to predict who's going to do well, and you know, it would be nice in the abstract if they had showed you how many of those patients for weight regain and how many for reflux, because there are so many other papers that show that if you do a bypass for weight regain in a sleeve, you don't really have great success doing that. But it's interesting to see how much they got 9% more, which excess weight loss in the patients that were converted, which, you know, if you're talking about someone has an extra 100 pounds, 9% is just, there's a 9% difference, 9 pounds difference between those two groups, you see, at 15 years.
Yeah.
Which does not seem as clinically significant versus, you know, if it was 9% in total body weight loss would be a lot, it would be a fair amount more.
But I think what I'm concerned about the conversion rate is too high, you know, is almost 50%. Yeah. If when you have the patient, you might say to him, maybe you have 50% of rate of conversion in the long-term follow-up. So that is my main concern about the sleeve gastrectomy.
Yeah, and I think you guys in Latin America have been ahead of the curve looking at, is the BMI of, you know, greater than 45, should they really have a sleeve or should it be a bypass, you know, and the rest of the world's not been there. We've all been sort of like, let's do a sleeve, and if they don't do well, then we'll convert them to something else, you know, and so we've offered it to everybody. Anyway, so we've offered that to everybody, and then if they need more, we will offer another operation. It's a good paper to pick up because it does highlight a high conversion rate, and I think the follow-up though is excellent.
Yeah, absolutely. Okay, Manuela.
President-elect of Ifso is actually the final author on that paper you just presented.
Oh, I see. Okay. Right. So in the next paper, also from UK, it was a cohort analysis of consecutive diabetes patient who underwent bariatric surgery in not requiring diabetes medication 12 months after the surgery. 105 patients with type 2 diabetes underwent bariatric surgery, 89 Roux-en-Y, 16 sleeve gastrectomy, with a median follow-up of 19 months. The initial weight, the BMI was 42. 64% demonstrate type 2 diabetes resolution at last follow-up. In conclusion, more than one anti-diabetes medication, insulin therapy, and longer duration of diabetes preoperatively increase the likelihood of persistent diabetes post-surgery. Type of operation, preoperative BMI, and percent of excess weight loss did not predict remission. Marina, what do you think?
I think they should be putting these patients, I sound like a broken record. These GLP-1s are so amazing. I put all my patients on it if they have a diabetes post-operatively, and it's amazing. And it works, it even works with type 1. You have to work with the endocrinologist to get there. But yeah, we already have some of this data. It's nice that they did it in, you know, but the follow-up is only 19 months. And it's single center. But yes, if you're on multiple medications and insulin therapy, and if you had diabetes, and you know, we have articles that talk about 5 to 7 years or greater duration and what could be the resolution, right? So I wonder, mainly because this isn't a UK system, if the follow-up was affected and what the access was in the NHS for these patients and to further treatment and care, and if there's any problems with their queue, you know, because that can affect your outcomes. I see my patients every 2 months if I put them on meds.
Our concern in Latin America is the access for GLP-1s medication. That is highly costly for our patients. That's why we cannot put all of them. Perhaps there are some paper from Ricardo Cohen. They are giving to all the diabetes patient metformin, so they can see at the long term follow-up better result if they don't take any medication. But I don't know yet the result of those studies. So in the last paper, Manuela from Spain, it is a retrospective review of prospective collected database, was made including consecutive patients who underwent a gastric endoscopy application for obesity treatment. Patients were followed up for 24 months after procedure, and the result was from 82 patients who underwent endoscopy sleeve, 67% were female, and the BMI was 36. At 2 years, the mean total weight loss was 19%, and the excess weight loss was 66%. No serious adverse events were reported. So in conclusion, the study shows that the gastroplastic and endoscopic sleeve application is an effective and safe procedure for obesity treatment, but it's necessary more study at long term. So it's more like you present before, right, Marina?
Yeah. You know, this actually shows greater total body weight loss in the MERIT study, but the MERIT study was very controlled. And so the BMI was also 36. So definitely in the 30 to 40 range.
Exactly.
It's pretty good. And it's interesting to see that the weight loss was so high at 2 years still, because that's what a lot of the other papers have shown, that there's some weight regain in the second year, and that, you know, these procedures are repeatable is what we hear, right? And we see it in surgery, so why would this be different? We should see that there's some weight regain. It's interesting.
Yeah, I think. Yeah, very interesting. Okay, thank you, Marina, for your comments. Now, I would like to introduce my friend, Sebastián Arana Garza from Mexico. He is founder of Bariatric Surgery Expert, University of Monterrey, Nuevo León, Mexico. Hello, Sebastián.
Hello, good morning from Mexico. Let's begin. I choose 3 papers, so let's begin. The first one is the impact of aprepitant on postoperative bariatric surgery as an antiemetic utilization, patient satisfaction, and cost. So this is from a database. 400 patients were reviewed in 2 groups, aprepitant group and non-aprepitant group. The procedure were sleeve gastrectomy, gastric bypass, and duodenal switch. All of those procedures were with Da Vinci, oral Da Vinci procedures. So the non-aprepitant group patients were given pre-op unless they had allergies, scopolamine patch, dexamethasone, and ondansetron with promethazine IV. And the aprepitant group, the treatment was 75 milligrams of fosaprepitant, who was given 30 minutes prior to surgery, with an option of a second dose of another 75 milligram dose after 24 hours. If nausea and vomiting persisted despite of the standard care, which was ondansetron for nausea and vomiting every 8 hours, with promethazine also every 6 hours. So in comparison, for ondansetron, promethazine, and scopolamine patch, and dexamethasone were used significantly different in the aprepitant versus non-aprepitant group. For cost, we may think that this new medication may get a higher cost, but for cost, our results suggest that in the bariatric patient receive aprepitant, their antiemetic medication cost and cost of medication decreases. So it seems a pretty good option for those patients to use aprepitant as an antiemetic medication. Next one, please. Pedro.
Okay. Sebastian, in Mexico, is aprepitant used?
Yes, but we have just an oral presentation.
All right, all right. It is not. Are you planning to use it or?
Yes, when we do mostly private practice, so for us to add some new medications, we need to get cost-effective relation. And as this paper present, patients have more satisfaction. The mean patient satisfaction rose 11% in the patient who apply aprepitant, and comparing 6 months later, in the aprepitant group, they have a better experience from the surgery. So this is a very important fact. So it reduces cost. It gives a better postoperative experience. So for us, it's very important to look for this new medication and new approaches of the follow-up or the postoperative period. So yes, once we have this in Mexico, we'll try to apply it in every patient, as this paper shows.
Great.
Perfect. The second paper from the US is an indication from primary bariatric surgery conversion and analysis of 2020 in the MBSA-equipped database. So to report of choices in bariatric surgery and conversion, indication, and 30-day outcomes using new definitions of MBSA-equipped. They search in the MBSA-equipped database for surgical conversion from adjusting gastric band, Roux-en-Y gastric bypass, and a sleeve gastrectomy. Patients under 18 years of age, primary or revision surgery, those with an ESA classification above 5, and emerging cases were excluded. So at the end, they have 15,000 conversion cases, and after exclusions, it was around 12,000. Conversion from an adjusted gastric band to Roux-en-Y or sleeve gastrectomy was 47% of all cases. Conversion from a sleeve gastrectomy to Roux-en-Y gastric bypass represent 43% of the cases, and the rest of the conversion weight was 8.9%. So weight regain or an inadequate weight loss drove conversion in 63 to 93% of all cases in all categories, except sleeve gastrectomy to Roux-en-Y, which the main reason was to alleviate or ameliorate GERD in 53.9% of the cases. Concurrent hiatal hernia repair was performed in 28.5% of those patients with a sleeve gastrectomy to Roux-en-Y gastric bypass cases, compared to 12 to 19% in other categories. Conversion from Roux-en-Y gastric bypass was associated with high leak rate, 3 to 8%, and a greater risk of death, 0.6 to versus 0.11 to 0.2%, with higher readmission and reoperation rates. Next. In this table, we can see that in the square up in the upper part, we can see like weight regain was the main indication for all the conversions, and GERD in those with sleeve gastrectomy to Roux-en-Y, and the square in the lower part represents how the Roux-en-Y gastric conversion have significantly more percentage of morbidity, readmissions, and complications. So in conclusion, the most common indication for conversion surgery were inadequate weight loss or weight regain, and refractory demonstrating a possible anatomic predisposition in patients with a sleeve anatomy. Conversion from Roux-en-Y gastric bypass was associated with significant morbidity.
Thank you, Sebastian. My question, in US, you know, the revision surgery is the third more frequent procedures. And the first one is a sleeve gastrectomy. According with this AFTRA, the sleeve gastrectomy revision was almost 50% of all cases. And the main reason was conversion from a sleeve to Roux-en-Y was GERD. So do you think we are over-indicating a sleeve gastrectomy again? So
it's a very interesting topic, because evidence shows that even now in 2022, we do not know exactly why postoperative or de novo GERD occur. The evidence is not very significant to have an explanation. So in the last years, all of us are trying to study our patients better, to really try to do a sleeve in a patient without any risk of having GERD after the surgery. So maybe in the past, in the first cases of the database, it can be an issue, but being just a 2020 patients database, it may seem that it's something else. It's something that we already didn't get completely about the anatomy or the way the post sleep mechanics work, that some patients, even though we study them pretty well, they develop GERD no matter what we do.
Okay, thank you, Seba.
Next one. And the last one is an intrathoracic gastric pouch migration following laparoscopic sleeve gastrectomy and its impact on the gastric sleeve outcomes. All patients obviously underwent gastric sleeve in this hospital from January to October 2018. All were screened for intrathoracic sleeve migration up to 3 years. Symptomatic patients who failed to respond to medical treatment underwent an esophageal gastroduodenoscopy, and it was confirmed the intrathoracic sleeve or pouch migration, and were offered Roux-en-Y gastric bypass for quality of life and to assess GERD using a questionnaire for GERD. 346 sleeve patients were performed in a hospital by the same technique by the same team, with a dropout rate was 13.29%. The incidence of intrathoracic sleeve migration was found in 16%. The most common presentation of this migration was persistent vomiting in 66% of the patients, and a refractory GERD in 58.3% of the patients. Regarding management, 45.83% of cases agreed to undergo surgical revision to a Roux-en-Y gastric bypass plus a cruroplasty. The mean score of the questionnaire for improvement was in the operation was 47 to 29. So the p-value of that difference is statistically significant. Intrathoracic sleep migration should be considered in all gastric sleep patients presenting vomiting or GERD. Pre-op and post-op sleep gastroenteromy endoscopic assessment is very recommended, and CT with gastroscopy has shown a high diagnostic value for detecting intrathoracic sleep migration, and Roux-en-Y gastric bypass plus choroplasty is a valid option, if not the best, for repairing the intrathoracic migration and successfully managing weight loss in the patient with sleep apnea.
Great. Sebastian, what do you think about looking for always the hiatal hernia during the sleep gastrectomy procedure?
Okay, as we mentioned before in the last paper, we do not completely 100% of the biomechanics and the physiology of what happens with the function of the lower sphincter, esophageal sphincter in the sleep patient. So hiatal hernia it's a finding that most of us surgeons look in a patient doing a sleep. In our experience, like 70% of patients have some degree of hiatal hernia. So I strongly recommend to revise the hiatus and to fix if there's any opening or something to avoid this kind of finding in the future. But also, if we look to the evidence about hiatal hernia repair, we also know that all the repairs we do have a high risk of doing of coming back from the hernia. So we need to know also that even though we perform a choroplasty or a hernia repair, we need to look for this kind of findings, because also the reparation we perform may not be so effective in the future. So we need to do systematic revision of the hernias and systematic follow-up to look for migration, even though we repair it in the first surgery.
Great stuff. Yeah, thank you.
Thank you, Pedro. Thanks for your time, and hope to see you soon in person. So let's continue with our good friend from the Netherlands, Dr. Edo Arts. He's a bariatric surgeon, a medical director from the Weightworks Clinic and Allurion Clinic in Amersfoort, Utrecht in the Netherlands. Hi, Edo.
Thank you so much for the kind invitation, and I can imagine if you have to pronounce Amersfoort in English, it's quite hard. I'm gonna mess up with the next speaker as well. So I'm gonna keep it short, guys, because we're running out of time a little bit, I think, and I've selected 3 relatively easy slides. So Manuela, you can skip up until the conclusion every time. So this is an interesting abstract for me personally, because in those class 1 obesity patients with diabetes, which now have been internationally, let's say, approved to undergo bariatric surgery, it is quite hard to select the right patients who might benefit from gastric bypass surgery in this case. And for me, always challenging are those insulin users. And this study coming from Heidelberg, Germany, at least shows in only 16, but still 16 patients with a follow-up of over 5 years, that those patients are doing pretty well, even when they are on insulin for quite a long time. As you can see, they have a relatively low BMI because they are class 1 obesity, but they drop down up until a BMI of, let's say, around 25-ish. Everybody improved, and 1 in 3 even had complete remission, and that is stated when an HbA1c level was under 7%. So not completely international correct, but still good results there. What was most exciting for me to read, actually, that I always look on towards beta cell function, things like C-peptide, you have certain scores. And actually what comes out of these only 16 patients so far is that the beta cell function as we measure it doesn't actually predict diabetes remission at all. And that is quite surprising, because sometimes I'm quite hesitant because some of the predictors for, well, let's say worse outcome are the time you use insulin use itself, and bad beta cell function. It doesn't seem to come out of that in long-term follow-up. In short-term it might, but in long-term it doesn't. So in the end, patients on insulin and having obesity class 1 seem to benefit in any case, nephropathy and many others. So do keep in mind, and do keep a, let's say, surgical spot open for these patients as well, as the message.
Oh, you already answered my question, because I was going to ask you, like, looking in this data, especially in that insulin reduction, do you think that this metabolic surgery in those low BMI patients is really beneficial? But you already answered the question.
Yeah, of course, you can look at it any way. Of course, we now have new types of medication that I prescribe to many of my patients as well. But in these, hard to regulate, because keep in mind, these patients were hard to regulate, and many of them, of course, didn't undergo GLP-1 treatment. But still, if they're hard to regulate, I quite often even get these sent over now from my endocrinologist that feel on, let's say, liraglutide or whatever you want to name it. Or what's out there in your country, because that differs a little bit around the world, of course. But if these patients feel, again, have a warm heart for these in terms of bariatric surgery. Yeah. So next slide, Manuela. Thank you so much. Well, this one goes close to my heart, because there's only little information on long-term outcomes in terms of micronutrient and somewhat macronutrient deficiencies. Done a lot of research on this subject myself, and this study is quite a nice one, coming from Spain. And I must say that although not everything has been measured, well, let's say according to the, for example, ASMBS guidelines, you can see that even with this, let's say, only small measurements taken in those almost 350 patients 10 years after, so only looking at vitamin B12, iron, albumin, etc. Over, let's say, 75% of patients showed one or more deficiencies. And although asked, and it seems as if patients took their supplementation, and that's over the counter if I read correctly, so it's not specialized, we have to keep an eye out for these patients. We cannot lose them out of sight or make a plan with a GP or something, but these patients have to be followed up. Perhaps not every year, but measuring these and supplementing these patients, even in long-term, in the long term, it is very and seems to be very important. So as the author stated, and I completely agree, lifelong monitoring must be carried out, but it depends on who's doing it, as long as the person doing it is somebody who knows a little bit about the background of bariatric surgery.
Yes, this paper is really interesting, and it's pretty solid, because it comes from Valebron, from team, from Amadori, from Ramon. So we can easily understand that this data is pretty solid. So, but it's interesting to see this kind of data, because there's not too much of this kind of papers in nowadays. So do you think these findings are related to technique or related to follow-up?
On average, there's a couple of these publications out there that show actually the similar results, but you can count them on one hand. I only need my 5 fingers. But they all show the same. It is about, of course, surgery itself. On the other hand, patients with different eating orders, not disorders perhaps, but eating orders, tend to show kind of these kind of deficiencies as well, but not in these amounts or these percentages. So it is a combination of what they're eating, what they're supplemented with, and the long-term situation after surgery. So it's a combination of all.
Of course.
So next slide, Manuela. Now, there was already a little talk about bypass versus sleeves, etc., in a few prior presentations as well. But this is, for me, a special one. I think everybody knows the SOS registry coming from Sweden, and the Swedes have something special, and that's because a lot of registries are actually bound together. So if you go for a new driver's license, you are registered, you have to weigh in. So it's relatively easy to follow up these patients, at least on certain points, and especially on weight, for example. Now, again, another study coming from the SOS actually looked at the differences between sleeve and Roux-en-Y gastric bypasses, and specifically whether these two groups are different in terms of 4 categories. So having less than 50% excess weight loss, they had weight regain after they had their minimum weight achieved of over 10 kilograms, whether they still fulfill the Ifso criteria and the ADA criteria, and they made a mark at 2 years. So all the patients, so all 60,000 patients were included. And I can tell you that on average, I know because I've been to Sweden a couple of times, that the sleeves not performed that often. As you can see, there's a difference in between and Roux-en-Y gastric bypass, and as in many other countries, bypassing is European countries, bypassing is outweighing in that sense sleeves. It says something, but if you look, for example, at the outcomes here, then you see that not achieving an excess weight loss of 50% is up to 23% in sleeve patients. You see double the amount of regained weight within those 2 years. So keep in mind, this is not long term, this is even already short term. 8% patients fulfilling the Ifso criteria and 3.3% the ADA criteria. So you cannot really totally state, I think, the conclusion, but because of the high numbers, still 60,000 patients included, of which almost 8,000 sleeve gastrectomies, at least in a country where, let's say, bypass rules, it seems that although the outcomes are still good for sleeves, sleeves seem to be associated in comparison with Roux-en-Y gastric bypass on a higher chance of primary and secondary non-response. For me, being mainly a bypass person, for me, these outcomes make sense, but it doesn't mean that you have to shift, of course, your practice if you're doing sleeves as a primary procedure, because it's always something you discuss with your patients, what to choose in that situation, I think.
Yes, it looks one more time that Roux-en-Y gastric bypass has better results than sleeve, but there's 8% of non-responders. So what are your thoughts about these 8% of non-responders with Roux-en-Y gastric bypass? What are we missing? Is something related to the patient? Is something related to technique? We all know that there will be a percent of patients which are not responders, but what are your thoughts about that?
Well, I'm a little bit hesitant to use the term non-responders, because they did respond, but as not as much as you would like to. If you would not have operated on these patients, then of course they wouldn't have lost the amount of weight that they would. So for example, the study that Marina showed earlier, in sense, after 1 to 3 months, we already knew that because there were a number of other studies coming out like 5 to 10 years ago that showed exactly the same. And there's a sort of intervention you can do in these patients to get them up to speed a little bit more. And now with the added medication, perhaps we can do support them a little bit better. But what it is, I mean, everybody is different. I mean, it's of course the way the patient behaves. I mean, on average, if it's not that, for example, it has to do with the degree of scholarship. My patients, on average, who have not been to university are actually doing better than the ones that did. So there's all sorts of reasons why some of these patients still will not end up with the result that we together, so patient and surgeon and the whole team around it, expected. And I think it's different for every patient. So I can't name just one thing, it's so many.
That's correct.
Thank you so much, Sebastian. So it's an honor for me to actually present a good other friend of ours. So I hope that you are able to join us. Yes, there he is. So you have a full list, and I'm trying to pronounce them correctly. So MMBS, NMED, in surgery, NCI, FREX, G, general surgery, FIX, FAMS, and FAC. So I looked up a couple of them, and quite impressive there. So you're the Assistant Chief Medical Informatics Officer, Senior Consultant, Upper GI and Bariatric Surgeon, and you're doing that at the Tan Tock Seng Hospital in Singapore. So we're relatively close by now. So I'm now currently in Australia, still far apart, of course. I would like you to take the floor. So surprise us.
Thanks, Thanks, for the kind introductions. It's my honor to be the panelist together with all of you. Let us move to the next slides. Yeah, sure. So this is the paper I have chosen. This is a primary obesity surgery endoluminal post-2 for the treatment of obesity, result of 2 years. It is a pretty short-term results, which is published by the Spanish group. So it is a post-interrupted full-thickness plication of the gastric body. So they use the 4 rows of the folded plication with the 4 to 5 plications per row in the body of the stomach. So they recruited 79 patients from 2018 September to January 2020 at the HM Sechenaro University Hospital in Spain. So the primary outcome for them was to evaluate the percentage total body weight loss in 2 years, and then secondary outcome was to assess the safety. So you can see at the table, the number of patients recruited was 79, the average age was 50 years old, 67% were female, and the mean body weight was about 109 kilo, and then initial BMI was 38.2. So there were all patients have a technical success, and then the mean sutures placed about 18. The length of stay was quite impressive, of 1 day or the maximum 2 days. However, there was an advanced event of the 2 gastric perforation and 2 asymptomatic anemia noted in their study group. Regarding the 2 gastric perforation, they noted during the endoscopy, and then they managed to repair on the spot itself, so that not much of the long-term complications from these adverse events. So they managed to 100% of the patients completed the 12 months of the follow-up, 95% completed 18 months follow-up, and only 59% completed the 24 months follow-up. So among the follow-up, you can see that the weight loss and percent total body weight loss and BMI is acceptable. So they concluded that post 2.0 is safe and effective. Weight loss maintained in 2 years. So I would just say that this is still quite a short-term outcomes, and that we still need the long-term outcomes to see whether it will have a similar effect. And then we all know that with the gastric plications and endoscopy, right, it tends to not sustain the weight loss in the long terms. Then the post-surgery, post-regain or remission of the weight regain, all these things, not sure whether we'll have the possible to do the surgery safely or not. These are the things we need to look into it in the future. Yeah.
So very interesting, of course, and there's more where that came from, I think, with your second presentation a little bit. Just going through what you told us, the conclusion of the authors is POST is safe and effective with 2 gastric perforations in only, what was it, less than 100 or 79 patients. Can you live with that conclusion in this sense? It's an endoscopic procedure, so is it safe?
Yeah, so I think maybe they might have some learning curve from the applications, because even though numbers are 79 patients over the 2018 to 2020, so there might be I'm not sure whether they are in the early phase of the cases, right? So, I don't know the information. There might be the 2 cases of perforation are in the early case, but they managed to find it endoscopically. They managed to identify the perforation and then the repair immediately, and then not much was equally. So in that case, that I would say that's still quite an impressive results. Yeah, provided that after the learning curve. So these 2 cases are towards the end of the 79 patients, then might be a little bit concerned, right? Because of it is still safe with after experiencing the over 50 patients in their hands that still get a perforation, then we may need to ask it whether it is really safe or not, as per your concern.
Perhaps the conclusion is still a little bit preliminary, but and you shared that you already experienced that the weight regain is there. Is there a specific group you can target on that weight regain? Is it all the way? Is it every patient that has weight regain, or is it specific patients?
They didn't mention about this. So for that, I suspect is the after the endoscopic treatments, I think the 2 years is still, I would say, considered still pretty short, because the only 59% are completed the 24 months of the follow-up in their study. So I think we still need to look at the follow-up studies, right? So I really don't know whether all the patients have the successful weight loss after the 24 months follow-up. Yeah.
I can imagine. So let's go to the next then.
Sure. Okay, next one, please, Manuela. So I also chose because of the first one I chose post, so second one I chose the restorative obesity surgery endoluminal rows for the treatment of the weight regain after the surgical weight loss procedures. The preliminary results are, this is only 1 month's follow-up, but it's interesting because it's also something we can help with the more, the less invasive procedures endoluminally for those with the revisional surgery to the weight regain, so that the patient might not go through the risk of the surgery, which is quite challenging to some of the patients with the weight regain. So this also from the Spanish groups. So ROSE is the procedures intended to help patients to reverse the weight regain by multiple full thickness plications. They use the incisionless operating platform from the United States. So they restore the pouch and stoma size, and then retrospective review of the prospectively collected data. So for the G-prox, they use a 16 mm for bypass, and then they use the 33 mm for the sleeve. They follow for 12 months. So from the table, you can see that there are 70 patients they recruited. The average age is about 45 years old, and then the average weight is about 96. So not so bad. BMI is 35.45, and then the expected excess weight loss is about 36.86 kilograms. So in the follow-up for 12 months, they didn't mention about how many patients, all the patients, 70, I suspect all the 70 patients have completed the 12 months follow-up. I suspect so, because it's quite pretty impressive that percent weight loss and percent total weight loss are quite significant in their results. So it's possible to consider as a therapeutic interventions for the weight regain in patients with the bariatric surgery. However, as I mentioned earlier, this is still pretty much early data, and then we need a long-term follow-up. But these are things we can help the patients to avoid the revision, the major surgery, and then to achieve the certain amount of the weight regained with these complications. That is something is interesting, and then we can look into it. Yeah, thanks, Edo.
Yeah, I think you already mentioned it all. I mean, we're always struggling with these kind of patients. How can we help them out, right? And it gives us another tool in the box, let's say, to help out these patients. And although it's a few patients, 17 only, and we only have a year of follow-up, these do seem promising. So let's hope this group will provide us with more data in the future. Yeah, thank you.
Yeah.
So let's go to your last one, I think.
Thanks, Edo. Yes, last one. Next one, please, Manuela.
Yeah, it's already there.
Okay, so next one is what I chose was about the same day discharge room-wide gastric bypass. I think earlier we talked about the early discharge for the C gastric from the Singapore, one of my colleagues, Singapore General Hospital study about the hydration clinic. So this is also something we need to look into it about whether same day surgery for the RIGP patients. So this from the study from the USA group about so we know that SDA same-day discharge after bariatric surgery is gaining popularity, and then the post-operative outcomes for the SCD in their paper. So they used the retrospective analysis of the NBS group database from 2015 to 2020, about 5 years data. So they exclude those patients who die on the same day of the operations, and they excluded those patients who were not readmitted, were excluded. So the primary outcomes from their study was 30-day morbidity, readmissions, reoperation, and mortality rates. So you can look at the findings on the right side of the slides. So total 276,000 RGP patients were operated during the period. About 1.2%, which is 3,264 patients were same-day discharge patients in RGP. It's quite pretty amazing. And then STD rate was 0.9% in 2015. And then you can see the popularity increase in 2020 to 2.2%. So mean age was about 45 years old again. And then most of them, 82.8%, were the female gender. The mean operated BMI was 44.9, and then most of them have undergone the laparoscopic RGP in 83%, robotic about 11.7%, and other in the 0.3%. I don't know what are the others. Maybe they did a hybrid or hand assisted. I'm not sure. They only mention the other in their abstract. So about 15.1% of the cases were revisions or conversion to RGP. So they are pretty much of the 15 patients were revisions surgery or conversion surgery, and then they did manage to go through the same-day discharge RGP in the group. Is quite interesting. Post-operative, even the revision surgery, which is quite challenging, or conversions to RGP, despite that they still managed to perform the same-day discharge in their study in the database. The mean operating time was quite impressive, about around 1.5 hours to 2 hours. And then the 30-day morbidity was 7.4%. I don't know what were the 30-day overall morbidity, but the 30-day readmissions were about 5.2%, and reoperation was about 1.7%. And then the mortality was less than 0.03%. So they concluded that after the RGP is safe and more frequent among the MBS centers, performing more and more day case bariatric surgery in the centers. However, we need to identify what are the preoperative and intraoperative variables which are associated with the poor outcomes. It will help us to define what will be the patient selections for the safer and more effective discharge protocols for the same-day discharge for RGP.
Well, thank you, Ang. I think this is up and coming, of course. We do this all the time already in the Netherlands, so we're pretty used to same-day discharge already. So many centers already discharge the first of the 6 patients of the day for a long time, and the outcomes are excellent. So what I'm surprised about here is the operating time, which is pretty long, and the standard deviation is quite great. So there's probably a lot to win there. Do you actually know when patients are discharged? Are they discharged home, or are they discharged to a care center, for example, a hotel or whatever that provides additional care? Is that mentioned in the article?
It was not mentioned.
Okay.
It was not mentioned.
But you do agree, right, that same-day discharge in many patients is possible. If some people you don't even need monitoring at home, although it is available in many countries now. So that might be ideal for some to send them home with a device that can measure something.
Yes.
But yeah, we'll see more of this in the upcoming 10 years, I think.
I think it's you're right. Yeah.
Sorry.
Yes, you're right. Yes, Edo, yes, it's correct. Yeah. So because nowadays we have more and more monitoring devices available. I think in the future, and integrated into the EMR, electronic medical record site, patient can safely the monitor at home, and then the alert will come to the integrated medical EMR systems to achieve the day case more and more in the future. I totally agree.
Yeah. Thank you so much, Ang, for all the answers, and speak to you soon.
Thanks. Okay, so without further ado, let me introduce the next speaker, who is Dr. Hazem Momani, who is the bariatric surgeon and chief of surgery at the Danat Emirat Hospital in Abu Dhabi in UAE. Unfortunately, Dr. Hazem cannot join us today, so instead Dr. Ahmed Bashir, who is from Jordan, also our chair of the Ifso Communication Committee, which all you might well know. So I would like to invite Dr. Ahmed, who is our chair, to continue the sessions. Thank you, Dr. Ahmed.
Thank you, Ang. Thank you very much. So Hazem selected the first 3, and I'm going to present the 3 following those slides. The first one that Hazem selected was revision of sleeve gastrectomy weight regain after sleeve gastrectomy to either SADIs versus Roux-en-Y gastric bypass. And the design was retrospective from 2011 to 2017. So that's a wide area or a longer period of time. They had 22 SADIs compared to 42 Roux-en-Y gastric bypasses. And they found that SADIs provides more weight loss, 73.7% versus 51.2% excess body weight loss. And the most frequent complication after Roux-en-Y was small bowel obstruction, 8.6%, while SADI's malnutrition, 6.4%. And the SADI's group had significantly better resolution of hypertension and diabetes compared to Roux-en-Y gastric bypass, 66.7% versus 10% and 85.7% versus 25%, which is surprising to me considering the previous remission rate numbers that were mentioned in prior revisional cases. And the reintervention rate was similar between two groups, and their conclusion was that SADI is the preferred revisional procedure after sleeve gastrectomy, and it offers better resolution for diabetes and hypertension.
Thanks, Dr. Bashir. So I'm not sure it's fair to ask you because you're helping Dr. Hazem to present. So just on those few things, I'm not sure whether did they mention that they did the RIGB in the earlier group, the revisions, and then the SADI in the later part. So I'm not sure because even though the right SADI, the nutrition monitoring rate is 6.4% is quite alarming for us also. Yeah.
It is, and I wonder that too, given that SADIs became more popular later on. So early on, they were probably doing more Roux-en-Ys. And the question that would we all wait for the manuscript, what is the limb lengths in the Roux-en-Y gastric bypass group? Do they perform longer BP limb versus shorter BP limb? And the patient selection, again, it's a retrospective study. So wonder what the severity of diabetes was among the SADIs group versus the Roux-en-Y group.
Thank you.
Next one. So the next one is, again, endoscopic sleeve gastroplasty. And this paper came from two centers. They looked at three different patterns of sutures: the transverse bilinear, which is almost like a horizontal mattress in surgery, versus longitudinal versus transverse monolinear. And they looked at number of sutures and number of stitches and evaluate total body weight loss and excess weight loss in these three groups. And 88 patients and 69% were females. The average BMI was around 39, which is a heavier group to do endoscopic sleeve gastroplasty for. But there was no difference in total body weight loss or excess weight loss, and there was no difference in number of sutures, the total body weight loss, excess weight loss among the three different groups, three different suture patterns, and the number of sutures or stitches applied. And the adverse events were similar as well, and they noted 60% resolution of obesity-associated medical problems among all the groups. So the three different patterns provide the similar outcomes in the first 12 months.
Thank you, Dr. Bashir. So I think this one is quite interesting to me because they mentioned about it's a prospective study of over 5 years period from 2 units. Then in the end, I'm not sure they didn't mention about what is the percentage to the body weight loss or is the weight loss over the 5 years, because the conclusion was interesting because it's safe and effective at 12 months, regardless of the number of the sutures and stitches used. But I'm not sure about the 5 years data. Yeah.
So yeah, from the abstract, you can only get this, but considering the manuscript, you'll know more about the follow-up and the follow-up percentage, who completed follow-up, who completed 5 years versus only 1 year. And it seems from the abstract that they had only 1 year. And again, it brings us to the metabolic background of surgery. Regardless of the way you do it, it's almost, if the end result is almost similar, the metabolic response should be similar. So
I totally agree with you. Yeah. So because it's interesting that they managed to 5 years or not. So if we can have a 5 years data, would be quite good to know that in the manuscript. Yeah.
We'll look for it. Next one. So the next one is banded Roux-en-Y gastric bypass over non-banded Roux-en-Y gastric bypass, and it's a multi-center study. And it was done between July 2013 to December 2014 in 2 units, and the cases were followed up for 5 years. So 1.5 years, they accumulated 375 patients. The mean BMI was 44.5. It doesn't mention if there was any difference between the two groups. 184 patients underwent a non-banded Roux-en-Y versus 191 banded Roux-en-Y. The total weight loss was superior in the banded group, 32.6% versus 27.6% at 5 years, and that was statistically significant. And the complication rates were similar in both groups, and the obesity the associated medical problem resolution did not significantly differ between the two groups. So the banded was superior in achieving more weight loss, but not metabolic response.
So this is also interesting that they didn't mention about the who were the patients they choose as a banded, and what are the patients they choose for the non-banded group. I'm not sure, is it 2 units as a different, or they just missed both centers doing the both banded and non-banded.
Again, that question would be perfect to look at the full manuscript, but again, would you choose patients who had reflux, esophageal dysmotility to undergo banded Roux-en-Y gastric bypass? Not sure what the answer would be. It would be great if we find out that answer, if we randomize those patients between banded and non-banded in the future.
Definitely. Thank you very much.
Thank you, Ong.
So in that case, I don't need to introduce anymore.
Yeah, on to the next one. So let's start with my slides, please, Manuela. So the first one is a long-term study of a randomized controlled trial that looked at reflux and Barrett's esophagus among patients who underwent sleeve gastrectomy and Roux-en-Y gastric bypass. It comes from New Zealand, and they had randomized 109 patients in the past between sleeve and Roux-en-Y, and they called those patients back to undergo GERD quality of life questionnaire, gastroscopy with routine biopsies, and their primary objective was focal or Barrett's metaplasia, and they classified Barrett's according to the Prague classification. So out of the 109, they accumulated 48 patients. 26 had sleeve gastrectomy and 22 had Roux-en-Y gastric bypass, and the mean follow-up among those patients were 7.4 years up to 9 years. 8 sleeve gastrectomy patients had Barrett's and focal metaplasia, 6 Barrett's esophagus, 2 focal metaplasia, while Roux-en-Y had only 3 patients, and that was approaching statistical significance, but no statistical significance was found. No difference in long-term Barrett's, 1 in each group, 1 patient in each group. However, the regurgitation score was higher for sleeve gastrectomy, a little bit, no, actually 7.7 for sleeve gastrectomy patients and 11.5 for Roux-en-Y gastric bypass. The mean heartburn score was 8.4 for sleeve gastrectomy, while it was 9.1 for Roux-en-Y gastric bypass, and the PPI use was 23% versus 50% for Roux-en-Y gastric bypass. the PPI usage before Roux-en-Y gastric bypass was a bit lower. It's 36.4% compared to 54.4% post-surgery. And the excess weight loss was greater in Roux-en-Y gastric bypass, and the diabetes again trended towards Roux-en-Y gastric bypass, diabetes resolution, that is. So more metaplasia and Barrett's esophagus in sleeve gastrectomy as opposed to Roux-en-Y gastric bypass, while the surprising result is that GERD scores, PPI use, regurgitation score was similar among both groups. And again, it brings us back to what Zahir mentioned in his initial study, symptoms, GERD symptoms. And again, maybe we need to look at GERD symptoms again, post-Roux-en-Y as well as post-sleeve gastrectomy.
Thanks, Dr. Bashir. I just want to see whether they also because PPI usage in the pre-RGP was only 36.4%, but the higher in the 54.5% in the pre-surgery group, right? In the pre-sleeve, yep. I assume.
Yes.
Then, despite that, it's a GERD. They still randomize into the sleeve because of the randomization issues, I think.
So I think it's an old study, and they just called the patient back. Doing a randomized study, I would not select GERD for Roux-en-Y since it's randomized. So the idea of randomization is just to randomize both equally, and hopefully you'll get GERD similar in both groups. Pre-op and look at the post-op outcomes.
Yeah, I think so. Yeah, thank you.
Thank you, Ong. Next one. So the next one is the prevalence of reflux and Barrett's esophagus after laparoscopic sleeve gastrectomy versus Roux-en-Y gastric bypass in the sleeve pass study. So we all know the sleeve pass randomized control trial, 10 years outcomes are available, and it was a multi-center study randomizing patients between sleeve and bypass, 240 patients. The primary objective of this study was weight loss at 10 years, and the secondary was prevalence of GERD, Barrett's esophagus, and remission of obesity-related problems. And 84% of patients completed the follow-up on weight loss and remission of comorbidities, and 77% underwent upper endoscopy. The weight loss was a bit higher in the bypass group as opposed to the sleeve group, 43.5% after sleeve, 50.7% after Roux-en-Y gastric bypass, approaching statistical significance again. And the complete or partial diabetes remission was higher in Roux-en-Y gastric bypass, but it wasn't statistically significant. Hypertension remission again was higher in the Roux-en-Y gastric bypass, and this time it was statistically significant. Esophagitis was higher in the sleeve gastrectomy group, 30.4% versus 7.1%, and there was no difference in Barrett's esophagus, 5.4% versus 3.5%, and the reoperation rate was a bit higher in the Roux-en-Y gastric bypass group, but there was no statistical significance. So Roux-en-Y gastric bypass provides more weight loss, however, without actual statistical significance, but hypertension remission remains statistically significantly higher after Roux-en-Y gastric bypass as opposed to sleeve gastrectomy, and esophagitis was more prevalent in sleeve gastrectomy.
Thank you, Dr. Bashir. So I think this one also similar because there are quite high numbers of the esophagitics in the sleeve groups. So in the 10-year, this is a 10-year study. So after 10 years, those esophagitis will become a chronic esophagitis in the stem metaplasia, and then will transform into the Barrett's, or no, we don't know. We need to continue monitor those patients, I assume. Yeah.
Yeah, it's interesting that despite the higher esophagitis number in this randomized control trial, you don't see a higher Barrett's esophagus number. at 10 years. It would be interesting to see if it develops further down the line if they continue to follow up those patients.
Thank you.
Next one. So the next one looks at anti-obesity medications and the timing of administering anti-obesity medications. So they had, it's a retrospective review of 115 patients done between 2019 and 2020, and 21 patients were prescribed medications when their weight plateaued. Actually, the weight plateau group was 12 patients and the excessive appetite group was 7 patients. So the entire study group was 21 patients. The medications were provided for the patients who plateaued their weights in 12 cases, while in the indication excessive appetite was in 7. The timing of the medication was also classified into 2 groups: early medications less than 6 months and late, which is 7 months onwards. And the total weight loss, interestingly, was higher among patients who actually had early medication use and excessive appetite. So if you look at the results, 77.7% completed follow-up with a mean follow-up of 12 months. There was no difference in age, gender, or follow-up percentage, or follow-up period, or type of surgery between all groups. The total weight loss was greater in early medications and no medications group compared to late medications group. And the total weight loss percentage was greater for early excessive appetite, and no medications compared to weight loss plateau. So maybe if we give our patients medications early on for excessive appetite, or if you find the weight loss algorithm a bit, or the weight loss curve a bit slow, not steep, maybe we need to give medications early on, less than 6 months. If we show the graphs, Manuela, the first one is looks at the timing of medications, and you can see early and no medications have greater weight loss. And the next graph looks at the purpose of medications, and the excessive appetite group and the no medications group, again, since they're doing well without any excessive appetite, they tend to do better. Maybe intervening early would provide weight loss, better weight loss prior to weight loss plateau. It would be interesting to do a randomized control trial on that. So with that, we conclude the revision of the entire abstract. We took a bit longer. And I'd like to thank the entire communication committee for their strong work and reviewing the entire abstract book, which took a lot of time and effort, a lot of time out of their busy schedules, and for them to be here. Back to you, Lillian.
Yes, it has been a wonderful panorama of the best papers today. I admit I did not get to all the sessions in Miami due to conflicting commitments, so I have learned so much from today's presentation. So thank you very much. So thank you, Ahmed Bashir, and all the panelists who have given up their time today, not only to present, but also having spent time to source out the best papers to everyone. Again, I'd like to remind our attendees that you need to review these presentations. It is available on the Ifso website and a YouTube channel. Once again, thank you to all the attendees for attending. And remember, nothing beats better than coming in person to the World Congress. So see you all at the next World Congress in Naples in August 2023. So thank you, everyone. And once again, thanks for participating. Thanks for attending. Thanks for presenting.
Thank you. Bye-bye.
Thank you. Thank you.